like to welcome everyone to trauma module number 5, the journal club portion, and module number 5 is focusing on approaches to malunions and non-unions, tips and tricks. I'm Dave Stockton. I'm at Vancouver General at the University of British Columbia. I'm honored to be the moderator for this evening, and we are very lucky to have two esteemed faculty join us, Dr. J. Spence Reed from Hershey, Pennsylvania, and Dr. Malcolm DeBon from Duke, North Carolina. All of our relevant financial relationships have been disclosed and mitigated. In this journal club, we have a couple of experts, and we're going to get their opinions on a number of cases and discuss some really seminal studies in the non-union literature. Disclosure, this journal club does focus predominantly on non-unions, as we felt that we would get the most benefit from doing a really in-depth dive into that topic. We've got some fantastic cases and pieces of literature to discuss around that. We're going to discuss some of those articles and how it's changed and influenced our practice. We're going to discuss some of those best practices, and most importantly, we're going to have some lively discussion around some particular cases and applying some of the principles from these papers to those cases. In the email from this webinar, the 4 articles that we're going to be speaking about are listed. I will start, followed by Dr. Reed, speaking about some really important points on strain and an article around that, followed by Dr. DeBon, speaking about the article on the multifactorial etiology of fracture non-union and the importance of looking for infection. I'll finish with a quick summary of the bone healing and non-union theory paper. And throughout this, we will have cases to discuss and apply some of the principles of these papers too. I'd like to make a quick plug for the upcoming osteotomy, lower extremity deformity non-union course taking place in Cincinnati, November 20th to 22nd. There are also some upcoming webinars that you can find out more about on the website. The final fireside portion of Module 5 is coming up October 21st, so don't miss that. Okay, so let's get into the first article, which was a seminal article by Dr. Brinker and colleagues out of Texas Orthopedic Hospital in Houston, Texas. There was a series of articles. This one, the first one, was on tibial non-union. There is another one on the health-related quality of life effects from femoral non-union as well. The purpose was to use self-rated health-related quality of life scores for patients with tibial shaft non-unions and compare their SF-12 mental component and physical component scores with other orthopedic and non-orthopedic conditions. They aggregated 243 tibia shaft non-unions, so a fantastic sample size. Their definition that they used was that no clinical or radiographic signs of progression to healing and little to no possibility of healing without further intervention. Their outcomes included the SF-12 physical component, mental component summary. They also collected the AOS lower limb core scale, the brief pain inventory, and a time trade-off questionnaire. In terms of the background of what made up their sample size, 49% of the cases were open, most commonly affected the distal third, and non-unions were found to be infected 18% of the time. This is quite an impactful figure here. You can see that tibia non-union has a worse physical component summary than many orthopedic conditions, including end-stage arthritis, but also worse than some medical conditions such as congestive heart failure and clinical depression. Similar findings for the mental component summary score. Now, one of the other outcomes which I found particularly interesting was that when asked about the time trade-off, patients were willing to trade up to 36%, or on average 36% of their remaining life in order to heal or fix their tibia non-union, which equated to on average 12 years of their life. So tibia non-union is devastating physically and mentally. I found that the outcomes from this paper were generalizable and they use patient-rated data to substantiate its impact. This is clearly and many times a chronic condition when it presents to traumatologists, but it does have an acute solution, and it is an opportunity to take people from quite a dark place to a place of reasonable function and benefit. So I'd like to take this opportunity to say hello to Dr. Reed, Dr. DeBon. Any comments on this paper, and I'll also unshare and hand it over to Dr. Reed.
Thanks. Yeah, I mean, I think that paper, when I first read it, made a huge impact on me. And I think it should make an impact on insurance companies as well when you're trying to justify treatment.
Yeah, I agree. It's pretty startling, like how much these patients are really in distress, right? And you kind of think about non-unions as something that has developed over time and like a chronic condition, but we really are tasked with being able to be the solution for them, and to help these patients live a higher quality of life as quick as possible. So there is a bit of urgency to it, which this paper illustrates.
Okay, so we're going to spend about 10 or 12 minutes here and really dive into some basic stuff. But I think it's useful so that we can make sure we're all on the same page. Strain I'm a mechanical engineer by background, and strain is something that, I should know exactly what it means. And I still struggle to really understand it on a deep level. It's often discussed, not always understood. So we're going to do a brief review. How do I advance my slide here? Let's see. Okay. So what is strain? So strain is how a material responds to loading by deformation. All right. Every material in the world will change its shape subtly when it's loaded. All right. So if we look at tensile strain or compressive strain, in which we elongate or shorten something, we can quantitate this strain by how much it moves over in ratio to what was its original length. So it's always a ratio of where it started and where it is. So this is axial strain. If we look at shear strain, now we're looking to how the material changes shape in sort of an oblique pattern. And we can also quantitate this by, if you look at the change in shape, that delta L over the original length. So it's always a ratio of how much it moved over where it started. So in orthopedics, shear strain, and we're going to focus on shear strain because it has significantly higher implication for orthopedic fracture healing than axial strain. So we're going to focus on shear strain. It comes from two sources. The first is translational shear strain, and the other is torsional shear strain. So whenever you're looking at something in torsion, remember that you're looking at shear strain. In an orthopedic situation, shear strain from an oblique nature, a high angle non-union, we all know that these are notoriously problematic because of the presence of shear strain. And, this is a hypertrophic non-union in the femur. And again, it's an multiple unlocked nails. This is a torsional problem. Look how big the callus is, but still not healing it. So this is an illustration it's incredibly simple, but I use this with residents, fellows, and medical students to really describe what strain is like. Okay, so imagine you're standing on a shore and you're tied to a boat that's 100 meters away. And this boat is just rocking up and down on a wave that's 1 meter. Okay, so if we ask the question, what is the shear in the rope that's holding the boat to the person? It's delta L over L. Okay, it's 1/100 or 1%. Okay, now imagine that you're pulling that boat closer and closer to you while the wave is still moving it up and down 1 meter, all the way to the point where you get it 1 meter in front of you. Okay, so it's moving up and down 1 meter, tied by a 1 meter rope. So ask the question, how much shear strain is in that rope now? Well, it's delta L over L, 1/1, or 100%. Now, just imagine that that boat is right in front of you, moving up and down 1 meter, and you ask yourself the question, well, how am I going to control shear strain? So one of the ways you might think about doing it is grabbing the boat, pulling it towards you, compressing it to your chest, and holding it, okay? Well, essentially, that's what compression does, all right? So people, I think, have a misconception about compression. It's indirectly useful, meaning it's a very efficient way to control shear strain through friction and interdigitation. But it's not magical in and of itself. Okay, you can grow bone at distraction. Ilizarov taught us to do that. But compression is an incredibly efficient way of controlling shear strain. So back to that boat for a second. So imagine that boat is right in front of you, okay, moving up and down, very, very high strain, okay, and you don't control it, okay, and I'm going to tell you now what happens to that region when you have uncontrolled shear strain. So the person who stepped in and sort of helped clarify this for us was Stefan Perrin, with his interfragmentary strain theory. And the other people have offered subtle variations on this, but this has held up fairly well over time. This first was presented in the English literature or the American literature in 1979. He was sort of a hero over in the AO world in Switzerland. And he stated very simply that a tissue can't survive in an environment that exceeds its strain tolerance. And he calculated the strain tolerance of the 3 types of tissue that will appear in a situation of secondary fracture healing. You first get granulation tissue, then cartilage and bone. Granulation tissue, kind of like a rubber band that will tolerate 100% strain, like that boat right in front of you. Cartilage about 10%, and then bone between 2 and 5% if you're looking at cortical bone or cancellous bone. And this is sort of the beginning of the link between mechanics and biology, okay? This is the strain tolerance. Now, something that we don't talk about very often with respect to the strain theory, and the reason it all makes sense is bone is a very aerobic tissue, okay? Bone has a resting oxygen tension. If you put a probe in the middle of an osteocyte, about 100 millimeter mercury, the same as arterial blood. And the only way it can maintain that oxygen tension is if there's an intact capillary network to provide that, okay? So, this is an animal model, and we're looking at, from the very beginning, we see vascular invasion that is attempting to cross, if you will, but it cannot cross until that strain field in the gap falls to that low level, which allows that capillary network to cross, okay? So this is sort of the other side of the mechanical biology link. Bone requires an intact capillary bed, and a capillary needs a low strain environment. And this is really the deeper link between biology and mechanics, okay? So if you want to ask the question, histologically, a fracture union is a bridging capillary network in many ways, okay? So the strain theory says that basically all the preliminary tissues help to create an environment stable enough to capillary network to form. And this environment, this stable environment, is a combination of your implant and the callus, okay, that you hope is going to form, all right? I think one of the, sort of a non-union machine is when you bring 2 bone ends very close together, you don't control the shear strain, and you damage the soft tissue to the point where it won't make callus. That's sort of a non-union machine, if you will. So, strain and regenerate bone, in Ilizarov techniques is the same. Shear strain will disrupt the capillary bed. So regenerate bone, fracture healing, all require control of shear strain to allow the proliferation of the capillary network. So Ilizarov and Stefan Perrin were actually on the same page with each other. So let's move on to bacteria and strain, okay, before we get to the paper itself. So, bacteria love a high strain environment. Why? It prevents tissue adherence. It's good for biofilm formation. And like I said, it prevents capillary formation. It lowers oxygen levels. It lowers antibiotic delivery because there's not a capillary system forming, and it impairs host defenses. So bacteria love high strain environments. So this is the paper that sort of reviews all this. This is from Injury in 2021. And they basically looked at all the preclinical studies of stability and how they relate to fracture-related infection. And what they found was that stable fixation, either relative or absolute, both promotes union and prevents fracture-related infection. And that there always needs to be a balance between stability, damage to blood supply, and when fracture-related infection occurs, again, if you have an immature biofilm present, you might be able to maintain your implant. That's the whole argument between implant retention and implant replacement based on the maturity of the biofilm. But then again, a stability, low strain environment is important to prevent recurrence of the infection and allow the fracture to go on and heal. Interestingly, what they also discussed, and I didn't realize this until I read the paper, what the stability issues, at least in animal models, were most notable with staph species and a bit less so with gram-negatives. And they really didn't explain that other than they think it needs a little bit more research. And the paper did recognize that the need for better clinical studies looking at stability and fracture-related infections, not just the preclinical animal studies. I think this was figure 3 from the article, and it really kind of summarizes the link between instability and fracture-related infection. They call this the vicious cycle of instability, that when you have instability and you have movement at the fracture site, ongoing soft tissue trauma causes inflammatory response, local immune suppression, you have an ongoing hematoma, all that supports bacterial growth, interrupted neovascularity, like we talked about, which affects the penetration of antimicrobials. It affects white cell chemotaxis. And then if you have an implant in place, the osteolysis and the biofilm on the implant causes bone resorption, furthers implant loosening, furthering motion, and a further supportive environment for the bacteria. And this is the whole problem with instability and fracture-related infection. One leads to the other, and then a vicious cycle starts and makes really both of them worse, both the fracture healing and the fracture-related infection worse. So I'm going to show you this case. This is an incredibly simple case. You're not going to think, oh my God, what am I going to do with this? But I think it really hits some basic topics. So this is a 32-year-old closed fracture, non-smoker, and this is an older case. He was in an X-fix, and this is a distal tibial locking plate that was put in through a MIPO technique with a 3-centimeter distal incision, slid up, and percutaneously screws were placed. Okay. And we're like, okay, this looks okay. It's, you can make an argument, maybe it's not perfect, but we were okay, happy with it. Now I want to make, comment that this region was not exposed or compressed. And so, pertinent to my previous comments, you can ask the question, what is the strain right in this region? Okay. It's close together. It's a simple fracture. It's not multiply comminuted, a little butterfly there, but this region is not compressed. And you can ask the question, well, it could be a very high strain, but we did it closed, so we didn't touch the soft tissue. All right, so let's see what happens. So we let him weight bear at about 8 weeks. Here's at 3 months. It's coming back with callus, which obviously means that there is some motion there. 5 months, he's feeling good. He's back to work. Everybody's happy, going, yeah, good. This was a nice bridge plate. 8 months comes back, and now we have a broken plate. And he's got a nonunion at this location. So you're going, gosh, that's somewhat annoying, right? So let's ask the question and go through sort of a little analysis, like why did this fail? So my hypothesis was strain was very high because of the small gap, no compression. because there was, we didn't take down the soft tissue. The callus attempted to control motion and the strain, but the fatigue life of the plate was exceeded. So what could we have done differently? Okay. Should I have compressed that by opening it, or should I have put a lag screw across it? The reduction isn't perfect. How about this? What if I removed those screws to increase the working length and improve the fatigue life of the plate? I don't know, or should I have just nailed it? That's what somebody told me. Well, you should have just nailed it, and the whole problem would go away. But I think from a strain theory standpoint, I think this is an interesting, phenomenon. What could we have done differently to change that outcome? Well, what we did do was we changed the plate and we put a lag screw across it. We didn't take it down. We just put a lag screw across it, put a neutralization plate on, and all was happy. So just sort of an illustration of the effect of the strain theory when you drill down on it. Okay, I am going to hand this off now to Malcolm.
Well, students, I just want to make a quick comment. I think that's if you go back to the last X-ray, there's a great example of if you guys can think about it in your mind's eye of just like promoting the right strain environment for that oblique fracture line. Like that's an elegant solution, lag neutralization that you instituted to generate absolute stability. And yeah, I really appreciate the principles there. Let me go to my slides. Greetings, everybody from Durham, North Carolina. Can everybody see that?
Yes.
Good. Okay, cool. All right, guys. So we're going to talk about a paper out of the UK. It's a multifactorial etiology of fracture non-union and the importance of searching for latent infection. And just a few slides here to run through the paper. So this was a paper of consecutive non-unions, about 100 non-unions from a series of surgeons, where the average age of the patient was about 40. And as you could expect, the majority of the non-unions were tibia fractures and some femurs, but all these were long bone injuries that went on to non-healing. About 34% of these fractures were open. And the authors really wanted to look at why the patient didn't heal and try to discern some factors as to why they may have not healed initially. And so they divide everything into 4 groups. So the first group was a mechanical issue. So basically, the patient had insufficient biomechanics to promote the healing mode that they wanted to achieve, right? Either too stiff for bridging or too flexible for primary bone healing, and having maybe a mismatch of the construct to the desired mode of healing. Then they also talked about infection being a risk factor for a non-union, and looking at the biologic local environment of the bone and citing maybe dead bone or bone that healed with a gap or that has a gap, meaning no cortical apposition, something related to like atrophic non-union. That was another reason. And then the fourth reason was related to the host, and they mainly talked about the patient smoking, I think it was over 7 or 10 cigarettes a day or something like that. But basically, the patient's behavior and their own host biology that is contributing. And so those 4 broad categories were brought up, and they dissected these 100 non-unions with expert consensus. And they actually found that the most common cause of a non-union was a mechanical issue. So, right, so that's an issue that the surgeon at the time of the index surgery maybe would have done something differently next time. So I think it's important for us as we treat these non-unions to, not blame the patient or blame the fracture, but a lot of the times we need to look at ourselves and figure out how we can optimize the healing for these patients, depending upon their fracture pattern and clinical scenario. But then again, there's also some other factors involved as well. So having compromised local bone biology was a significant causative factor, as well as a compromised host. So somebody that had habits related to smoking or was using NSAIDs, things like that. And then last but not least was also infection. So interestingly, on the top right, they looked at the percent of patients that had multiple factors contributing to their non-union. And it turns out the majority of patients that had a non-union had multiple issues, right? Not just one issue, but multiple issues that were attributable to their treatment failure. Another shout out to infection. One of the main conclusions from this paper was to really look at infection being a reason why there could be potential for that patient not to heal. And it kind of dovetails really well with Dr. Reed's presentation, looking at the biomechanics of fracture-related infection. And here we saw that in this series, even in patients that had no preclinical suspicion for infection, 2 out of 5 patients had positive culture results and had septic non-union. So need to have a high level of scrutiny for infection because this can be a modifiable factor to optimize your success for healing. So in conclusion, non-union etiology is a multifactorial but predominantly mechanical issue in the majority of patients. And the infection needs to be scrutinized for and can be an occult factor of non-union. So the author suggests to consider routine culture to guide antibiotic therapy for all non-unions, which, is a little bit of has 2 different camps to it. It can be potentially a controversial statement. So, I wanted to open this up a little bit for discussion for those that do routine cultures for all non-unions and see where that goes.
Thanks, Malcolm. Yeah, I guess I'm in the one camp in the always culture, because I don't want to be or have a family member be that patient who had no clinical suspicion, but has a positive culture. Because you have to ask the question, how would that treatment have gone if the culture hadn't been done, and a treatment for infection was not instituted? And so I'm also going to make this is sort of an editorial comment, if you will, but have a very low threshold for also doing fungal cultures, particularly if there was an open fracture. There's some thoughts out there that well, it's a healthy host. Well, I can tell you, you can get a pure fungus culture in a healthy host that if you don't, I got patients sending me a year out with non-unions, and the only thing I did differently was I did a fungus culture. So that's my editorial plea.
Yeah, that's great.
Now,
David?
yeah, Dr. DeBon and Dr. Reed, I think what kind of was highlighted to me in the paper that you just presented, Dr. DeBon, is that it doesn't seem like without doing culture, you can accurately predict who's infected and who's not infected. I was going to ask, how much stock do you put in values like CRP, white blood cell count, some of those markers that we use to look for infection? And even if, even if they're negative, do you still keep looking for it?
Yeah, it's a good question. I think it kind of goes down to multiple considerations. To answer your first question, I do look at the CRP a lot, and if the CRP is elevated, then it's a septic non-union until proven otherwise for me personally. Obviously, hard signs of infection, sinus tracts, or just really high risk injuries that were previously open. That again is like septic non-union until proven otherwise. But then, I take a little bit of a different approach, I would say. I try to diagnose the non-union based upon why did it fail. And if it has a mechanical reason, an issue related to insufficient stability, inadequate alignment, and our mismatch of strain, then I tend to focus more on that because it's a clear issue that's solvable via, non-union repair. And if I think it falls into that camp, I'm a little less enthusiastic about just getting routine cultures because I do think that sometimes we overtreat these patients with antibiotics for prolonged periods, which have their own consequences to them. That being said, and also I think that a lot of the non-union repair surgery is actually does a debris mod, exchange nailing, compression nailing with a reamer, etc. Stimulates the host biology and potentially could eradicate any subclinical infection. But that being said, it's controversial and there's risks and benefits to everything. So I do appreciate both camps.
A quick comment there. I think for me, I use it a bit as, am I going to go in thinking 2-stage versus going in thinking 1-stage? I mean, if I'll take cultures, but if everything looks normal, I may plan on a 1-stage, and if I get surprised by a positive culture, I'm like, okay, I've still laid some antibiotic beads in there, or I put antibiotics in my bone graft, or something like that. I've kind of covered myself, as opposed to if they're positive, I might going into it plan a 2-stage.
Yeah, that's a
Sounds
great
like it's, yeah, sounds like it's always something to, at the very least, keep in the back of your mind.
100%.
Yeah.
Speaking of that, I have a case. So this is a septic non-union, and it's going to be a little different flavor, but hopefully a nice illustration of some basic principles on how to manage non-unions, especially septic non-unions. So buckle up. So this was a 69-year-old male prisoner, and that's what, somebody who's incarcerated, who was 10 months out from a pelvic ring stabilization by another surgeon, diagnosed with a septic non-union, had MRSA bacteremia at the time of his presentation to the hospital with his non-union, and also had some open wounds. So, everybody kind of take a quick look at that construct that he had. And here are his inlets and his outlets. So, obviously you see screw loosening, you see instability of his pelvis with the internal rotation of the left of the right hemipelvis, and SI joint diastasis bilaterally, as well as some sclerotic and kind of osteopenic areas. And we'll roll through his CT scan here for everybody to get acclimated. So some pretty severe bone destruction and instability globally around the pelvis with an anterior obturator ring non-union there. Okay, so this is a tough one, right? So what's his problem? So he has an unstable pelvis, right? He's got bilateral SI joint diastasis and he's got a right obturator ring non-union. He also had a draining PSIS wound that was from a history of prior bone graft harvest for another procedure. So actually, he had a posteriorly based draining room. Again, I mentioned he was septic, that is physiologically septic with MRSA bacteremia. And again, his social situation, his kind of host factors were really important. He wasn't the most healthiest person. I think he had chronic kidney disease amongst a few other comorbidities, but he also was in prison. So, which actually can almost be a controlled environment, or it can be really challenging to have follow-up. So, have to kind of think it through this from a social driver perspective to try to optimize his care. So as everybody starts to contemplate, what are you going to do with this patient to help him? I'll just show you what we thought about. So this is a staged approach, right? This is by definition draining wound, instability, a fracture that hasn't healed, that had enough sufficient time to heal. Like this is a septic non-union by definition without cultures to me. And so, but the first stage I wanted to do is I wanted to get cultures, and I wanted to know if his anterior ring, which hadn't been previously instrumented, actually was a septic non-union as well. And so I debrided his open wound prone, his PSAS, and closed that. And then went supine and did an open approach to his rami fracture and debrided that not only just to get bone cultures, but I also wanted to create a bleeding bony bed because that seemed to me like it had enough instability that it became synovialized on the imaging. So I wanted to debride so we had clean bleeding bone that was amenable to healing as opposed to having like a pseudocapsule, pseudoarthrosis in the front. And then we got our cultures back. Turns out cultures were positive in the anterior ring, as well as obviously in the posterior ring. And so what we elected to do is to improve his reduction, provide stability, and deposit a local antibiotic slurry targeted towards his MRSA for infection control, all in one definitive stage. So we'll roll through this as we go through the fluoros, right? So um, again, I had already opened and debrided the anterior ring, so this was all percutaneous. This was all a closed surgery. So I used a anterior base X fix with a little bit of offset vector with the glute medial pillar pin as well as some AIIS pins. And you see the trajectory of my compressor distractor here on that bar, just really trying to externally rotate that hemipelvis to provide a better alignment to allow for me to place a medullary screw in the superior rami. And then here you see we're getting a little creative, but what I wanted to do was basically drill for my corridor for my medullary retrograde rami screw, and then use an endoscopic applicator here to place antibiotic loaded calcium sulfate, right? So you can kind of see it here, but there's a little bit of radial density right at that non-union site that was used with a kind of a tube that went through the cannulated, that went through the wire that for the guide wire and allowed me to place my antibiotic um, slurry. And after that, before it hardened, we placed our retrograde screw to add a point of stability. And then we proceeded basically with the same type of strategy in the back, but used the lag screws to compress this SI joint and to improve the quality of his reduction in the posterior ring. And then placed as much points of fixation as we could in the posterior ring as possible. Again, using the antibiotic slurry endoscopic applicator to preload the osseous fixation pathways with antibiotics as we placed our definitive screws. So here's our final construct. And turns out he followed up. He actually came to clinic 3 months after, and he was ambulating and he was off systemic antibiotics. His wounds were healed. And, to me, I think this was a really nice example of how you do need to consider all the reasons why patients may not heal: infection, instability, alignment, host factors, etc., and try to manage all of those issues as best as you can to provide that patient with the optimal result. So take home points from this case: optimal alignment improves stability, like don't compromise quality of reduction. If there's a reduction issue, you need to correct that prior to providing your mechanical stability for non-union repair. But rigid stability facilitates non-union repair. And it is important to try to provide as much stability as for that patient as possible to promote healing. Also, keep in mind that local antibiotic depot can help eradicate infection for like single stage non-union repair, as was illustrated in this case. And early weight bearing stimulates bone formation. So if you can create a construct that allows for that patient to weight bear as tolerated, that's only going to help you in the long run. So a couple minutes left for my portion here. I don't know if you guys have any comments on that case.
I think what I find really striking is that it was so obviously an infection non-union case, right? You two-staged it, but you also really maximize the mechanical stability in your eventual treatment, which I think really highlights that point. I was going to ask, um, between your stage 1 and 2, what are your preferred or options for local antibiotic delivery?
So, I used in the PSS wound, I kind of smeared vancomycin and topomycin on the bone. And I wasn't sure if the anterior ring had a septic non-union at the time, so I really just debrided and got cultures there. But we really work closely with our infectious disease colleagues, and this is a dynamic discussion. And I just remember having a cool conversation with one of my colleagues, Dr. Jessica Seidelman at Duke, about whether or not putting the vancomycin, which we needed for his MRSA, was worth potentially causing his creatinine to go up with CKD. And she was like, you know what? If it goes up, we can fix that creatinine, but he can't walk without a pelvis. Like, and it was really a cool conversation. Because I remember calling her like, what do I do? And she was on board to solve it together. So I really think that the key to this also, the elephant in the room, is just multidisciplinary care with your infectious disease colleagues and trying to be collaborative in these situations.
Malcolm, that's a great case. I got a question. When you took the hardware out, did you debride the path with anything, or did you just at the time of the
Yeah.
original the first debridement?
Yeah, that's a good question. I used an antiseptic wash in that canal or in that pathway. Like I squirted in like basically like a citric acid type solution in there. And obviously, the screw wasn't very solid, so I was able to kind of pull that out a little bit. So
Right, right, right.
And
So there's a
we have
go ahead. There's a
oh
question here. What type of tubing do you use for antibiotic injection or depot for the Ramus screws? I think they're asking the question,
yeah,
how did you technically get it into the
yeah. So there's an
yeah,
endoscopic applicator at our hospital for endoscopy. Like it's radio, at least a little bit lucid, but you can still see it on X-ray, and it allows for like precise deposit into a canal the size of a 7/0 screw. And so yeah, it's just something that we utilize, that we have, and I think it's available readily. It's pretty cheap too.
okay. The other question, comment I was going to make, and this is a really off-label comment about injecting liquid stimulant, which I think is still an off-label event, but everybody does it, is if you want to thin it and if you want to extend its cure time, don't use sterile saline. You have to use sterile water.
Hmm.
Saline will enhance its setting time, so it'll almost set up in the tube. If you use water instead to thin it, it will do what you want it to do. I learned that a little late in the game, so passing on a little tidbit there, off label.
great tips and pearls. Fantastic case. We went from quite a simple case to quite a complex case, and hopefully we'll finish with one that's kind of in between. Before we get there, you all can see my screen. We're on the unified theory of bone healing and non-union. I hope. Great. So this was a really fantastic, essentially thesis paper from the UK. And their purpose was to present a unified theory that links some established facts and theories about the physiology of bone and homeostasis. Their first sentence was that if the reader believes that medicine can only advance with level 1 evidence and prospective randomized controlled trials, it may be best to stop reading now. Which I thought was a little bit cheeky, but underscored that the importance of just thinking about basic principles and their application in terms which is really kind of, I think, a common theme in non-union and malunion treatment. Their bone healing and non-union theory is that the tissue that forms in and around a fracture should be considered a specific functional entity. It responds to Wolff's law, which states that bone adapts and remodels in response to the loads placed on it. Also responds to Perrin strain theory, which Dr. Reed gave a fantastic overview of, and also responds to Frost mechanostat, which is a bit of an extension of Wolff's law, but delves into the response of bone in terms of growth and loss being stimulated by local mechanical and elastic deformation of bone. So a couple of highly important graphs were presented in this paper. On one axis, you have net bone formation and net bone resorption, and then on the horizontal axis, we have strain. Okay, so point B is supposed to represent kind of normal bone homeostasis, and we'll zoom into that point on the next slide. Point A is situations where you have net bone resorption from such low strain environments, for example, in space, and also potentially could be considered, disuse osteopenic environments. And we'll talk more about the net bone resorption that may happen past point C, but that comes around in certain fracture healing scenarios kind of gone awry. So this is zooming into point B. And Wolff's law applies in this kind of homeostatic physiologic range, where kind of lower amounts of strain kind of promote a little bit more kind of resorption, and higher amounts of strain promote increased bone formation. What they describe throughout the paper is to think about the fracture non-union site and where it may be sitting on that particular graph. So it might be interesting, Dr. DeBon or Dr. Reed, if we think back to that first case that you presented, Dr. Reed, and that more proximal non-union line. There are two places on this graph where we don't see much evidence of bone healing. Do you think that was kind of that fracture healing got held up a little bit kind of to the left of point C, where there was some bone formation, but not enough to continue along the curve? Or was that construct so rigid that there was really no strain and therefore not forming much of the healing response? What are your kind of thoughts on that original case and where it may have
was
fit on here?
up near C. I mean, there was a biologic response. There was, but it looked very impressive on the plane film until the plate broke, and then you realize that there was no crossing bone in a three-dimensional structure really at all. And then I think that's because the strain was still too high.
Right.
It was trying but not winning.
Right. And it's a lower extremity fracture, and the loads experienced through those weight-bearing bones, it can be a little bit different than the types of non-unions and the mechanical reasons behind them for upper extremity fractures. Okay, so in non-union scenarios, the paper goes over how you can think about reducing the strain. They mention in passing there can be behavioral change by the patient, but I don't think we typically include that in most of our non-union treatment algorithms. Stabilization of the non-union. Somehow, and really kind of fixing it the way it kind of needs to be stabilized to mitigate those shear forces that you spoke about before, Dr. Reed. They make the point that there is no requirement to excise tissue from the fracture site, especially if we stick to those principles of pair and strain theory, exactly as you did in that initial case, where you didn't scrape out all of that fibrous tissue, because the reason that it was still there was because it just had its strain tolerance, or the strain that it was experiencing exceeded the strain tolerance of that fibrous tissue present in the non-union site. So once you neutralized that strain, it was able to propagate further along the pathway into bone. The use of autologous bone graft, they make the point that it's not necessary as long as the mechanics are well addressed. And they do also mention this Judet osteoperiosteal decortication as potentially something that can be used in addition, that may be helpful. And for attendees who may not have heard of that, it's a technique whereby the periosteum around the non-union site is split longitudinally, and a chisel is used to elevate little osteoperiosteal flaps circumferentially around the non-union site. And what that does is really promote a lot of osteoprogenitor cells and neovascularization to really kind of congregate around the non-union site. And this is in addition, I should mention, to addressing the mechanics of the non-union. And I think there's this might be a good opportunity to get the expert's opinion on the role of bone marrow injection and or PRP into the fracture site in cases of impending non-union or delayed union. Dr. DeBon, Dr. Reed, thoughts?
Yeah, I can just get it started. I don't typically do that. For me, as we kind of mentioned in the paper, most of the time if there's a non-union, it's a mechanical issue or issue related to alignment. And then the biologic issue as well can be addressed, but typically it's not like an off-the-shelf type solution. You have to really understand why the patient's not healing.
Yeah, I don't inject things because I don't think there's any place for it to go. I mean, there's no space. You're just putting it into tissue that's often relatively dense, and I think to your point, that I think that sure it's important to create an appropriate implant, but I also think it's important to what you do in a soft tissue standpoint. I think they're equally important. Although we all like to show off our hardware, I think what you're doing at the fracture region is equally important.
Mhm.
Great. So we're doing pretty well for time. And so let's discuss a final case that hopefully kind of wraps everything up, brings a lot of these principles together. So this is a 64-year-old female. Um, uh, and I met her quite a ways along her journey, but she presented initially with a fall to an outside hospital. She previously worked as a nurse. Her BMI is 51. She has type 2 diabetes that's reasonably controlled with a A1C of 6.1. Also has atrial fibrillation on rivaroxaban, and she was previously ambulatory in the community without any gait aids. So maybe just kind of initial thoughts on this fracture. To me, this is I'm gearing up for a challenging case, and one where principles really need to be paramount. What do you all think?
Oh yeah, I agree. This could be a challenging fracture. This is not one that's necessarily um, just fixed. This one can be a reduction challenge, especially in a larger person. You have to try to prevent varus, which this fracture naturally wants to go into. And there's some comminution there that provides some opportunities for instability. So it's a challenge.
Yeah, I agree. It's not length stable, or it would be difficult to make length stable unless you really did a reduction of the one butterfly fragments, and it's a super high stress region. Challenging problem.
Tough, yeah. And so it was reduced and fixed on a fracture table initially. Um, the probably highlights the importance of start point and trajectory of some of these nails, because maybe off the bat the start point was a little bit lateral there. The nail or the lag screw position in the head though seems overall reasonable, I think. And it looks like there was an attempt to get a sense of, some sort of anatomic reduction of that butterfly piece, but nothing necessarily to hold it there. So perhaps that Verbruge clamp was just used to get an overall sense of the alignment with the initial reduction in nail placement. These were the post-operative images, and she had persistent pain for a long time. Um, she also had the proximal area of her wound, kind of around a pannus that was persistently draining, eventually cultured Staph lugdunensis, and she ended up being treated with 3 months of Keflex and it resolved. This kind of attempt at healing went on and was followed for 12 months, but over those 12 months, the x-rays really didn't change too much. So the next attempt to get this to heal was to dynamize it by removing the two screws distally, and that happened at 15 months. Um, why or why not was that a good idea?
Yeah, so I can get started.
Yeah, go ahead, Malcolm.
Yeah, I mean, again, we talks about like why did this fail? I mean, it's in varus, right? There's not much cortical opposition, so there's not much intrinsic stability to the fracture, and so there's a mechanical alignment issue that's not going to be achieved uh, with just taking screws out distally. You know, as simple and maybe convenient that may be, I don't think that's the right answer.
Yeah, I think when you dynamize, you need to have a very, very specific reason for doing it, and you have to have a very specific thing you think it's going to achieve, and it should result in greater stability. And I think in this case, it resulted in less stability.
Hmm.
So that kind of concept of reverse dynamization, which was kind of what I think this needed more. And in addition to improvement in the overall alignment, and potentially addressing maybe a presence of infection, but not totally sure. So she was referred, a couple of days after she started to have excruciating knee pain, after this dynamization procedure. I wasn't quite sure what to make of the CRP of 12.9. Certainly, as an inflammatory marker, she had a number of reasons why it may have been kind of slightly elevated, but not markedly so. Um, and the CT also didn't show a specific pocket or a deep abscess. In her overlying skin, she had no sinus tract. And nothing that kind of pointed me towards a really hard sign that this was a septic non-union. Um, so, thoughts, ideas, um, Dr. Reed, Dr. DeBon?
Yeah, you know, I think you got the correct alignment. That's the biggest thing right now. That's the reason why this hasn't healed. So for me, that's an open approach, clamp-based reduction, new start site, potentially a revision nail with some type of adjunct to prevent varus. So because there's different options there. You could use a blocking screw on the proximal medial aspect of the femur. I can use a kind of a plate to tension that lateral spike down, and to hold like a nail plate combo. But there's different options. But the biggest thing here is to get it out of varus.
And I also think there's probably some, rotational component to that distal segment that it's unstable in rotation. And I would agree. I think a combination solution is the right way to go.
I was thinking along pretty similar lines, and for me, as I navigate these, sometimes I find that a lot of the principles that we talk about sometimes are in opposition. I want to maintain as much blood supply and vascularity and soft tissue as possible, but I don't think I can do that without an open approach in this. And also, I know that we don't necessarily have to take down some of the fibrous non-union tissue. But for me, in order to really get the mechanics back, and get this proximal fragment, especially out of varus, I thought I was going to have to do that. So that's what I did. I think I used a number of the techniques that Dr. DeBon listed there. I used the medial blocking drill bit initially, which I eventually exchanged for a screw. I moved the start point medially, still used the same lag screw path into the head because it was reasonable. And I did kind of neutralize or use a bit of a tension band plate to counteract some of those varus forces on the lateral aspect of the proximal femur as a bit of a kind of a insurance or belt and suspenders approach. So that was what we ended up with post-operatively. And I will mention that, in the back of my mind, I was thinking about that CRP of 12.9, but I didn't have any evidence of really hard signs of infection, and I did not intraoperatively either, though if I did, I would have probably staged it. And so I took a lot of samples, and I decided to use an antibiotic coated nail, or create an antibiotic coated nail, to give myself a bit of insurance. Also deposited local antibiotics. Also kept her on some systemic antibiotics until the cultures came back negative. And she's doing well at 4 months. She hasn't fully bridged, but she seems like she's retaining her hardware and laying down some bones. So hopefully she's on her way, but I wouldn't not completely out of the woods yet.
It looks great. I mean, your correction of her alignment is admirable. And just having that type of rigid fixation for that non-union, I think, was critical. So strong work. It looks great.
And you didn't, I mean, you got her length back, it looks like to me, like
Mhm.
that it's hard to tell for sure, but it looks like she's back out to length. Yeah. Yeah.
Think so. Hopefully.
I got a
Um,
question for you from one of the participants. The question
Great.
was, would you, if you had to fix this initially, would you have done a nail plate combination, or would you have just done the nailing in a perhaps more stable way?
Um, yeah, so initially, I would have approached this from a lateral position. Um, uh, Especially with BMI that large. I think these are exceedingly difficult on a fracture table, but possible. And I would have probably, I personally have a low threshold to open, reduce, and cerclage some of these subtrochanteric femur fractures. Because I've seen evidence that some cerclage wires don't necessarily compromise their ability to heal. And they don't compromise the biology as terribly as we kind of maybe thought they used to. And it allows me to, first and foremost, restore the biomechanics, which I think is when these go wrong, it's typically because of that. And so that's how I try to counteract that, is by getting that anatomic reduction. And so as a primary procedure, I probably would have used a nail and some cerclage wires.
I might have
Um,
reduced that and put some lag screws potentially across
mm,
the butterfly to reduce it prior to nailing. But same effect at the end of the day.
yeah.
Yeah. The only thing I would add is I would have a very medial start site with a more lateral offset nail to basically lean some valgus into the reduction.
Hmm. Absolutely. Um, okay, so I think we've been able to address all of the Q&A questions as we've gone along. Thank you, everyone. So, in discussion and to kind of conclude the Journal Club webinar, we spoke about an article that highlighted that non-union is physically and mentally pretty devastating for patients. We had some great kind of didactic teaching, focusing on and stressing that tissue can't survive in an environment that exceeds its strain tolerance, and bone needs that capillary network. So we had that really nice demonstration of the bridge between biology and mechanics from Dr. Reed. Um, the stability that promotes fracture union is equally important in preventing and treating fracture-related infection. And Dr. DeBon also highlighted that to always keep in the back of our minds that infection and its potential contribution, and it can be an occult factor. And then we finished looking at the bone healing and non-union theory, which ties together a lot of pre-existing theories and highlights that fractures and non-unions are specific functional entities that respond to Wolff's law, parent strain theory, and Frost mechanostat. I'd like to give some great thanks to Dr. Reed and Dr. DeBon. Your contributions have been immense and really influential. Any final words, also any kind of final questions from any of our participants?
Well, I'll just say one thing real quick. When you're trying to think about a framework for non-union, this is kind of the philosophy that I was trained with, but you want to look at alignment, stability. You want to look at infection, and then last but not least, the local or host biology. So those are the kind of my checklist. And remember, those first two, if not three things, are related to surgeon-mediated factors. So sometimes it just takes some introspection and reflection, really, to try to figure out the surgical solution for that patient.
I'd like to follow up on that comment, and I 100% agree. You know, if you look at that first paper and you recognize how bad a non-union is of the tibia for a patient, you know, you want to do everything you can to, in one treatment plan, resolve it. And it's really not the place for, well, we'll try this and see how it goes. All right. That's, you know, that's not the place to do that. This person is already, you know, potentially way down on the pathway of the job's a problem, you know, the family's a problem, the income's a problem, and they're personally suffering. And you want to offer them the best comprehensive plan for the most predictability of getting this thing to resolve.
Fantastic. Thank you, everyone. Thank you, participants. And don't forget to tune in to the third part of Module 5, which is coming up on October 21st.